All right. Hello, hello. Welcome, everybody. Happy Wednesday. Welcome to everyone who's joining us live today for our APRN webinar on is it an acute or chronic eye condition? My name is Hiva Kolodrubetz. I'm a family nurse practitioner. I am the director of advanced practice here at Archer and a nurse educator. So, however way you know me, I am really excited for today's webinar because I'm trying something new. We're going to gamify today's webinar so that you guys get to interact and test your knowledge and really find those areas that you need to go back and study a little bit deeper. So with that said, get your chat box open and I want you guys to start by saying hi in the chat and tell me where you're joining from. I really want to know where you're joining from and where you are in your NP education journey. Are you just starting NP school? Are you considering NP school? Are you getting ready to graduate? You have graduated, you're getting ready to sit for your boards. It really does help me be able to tailor this webinar to you guys and make it a little bit more fun for me and you as well. So tell me where you're joining from. Again, a little bit about me. I am a family nurse practitioner and I've been practicing for over a decade. I'm currently in the Texas area. I'm from the Boston area, the Northeast. That's where I did my training. And I've now practiced in 3 states, one on the East Coast, one on the West Coast, and now in the Southwest. So it's been a really fun journey practicing in different states and seeing how nurse practitioners are viewed in different states and how we are received and what our scope of practice is in all those different states. And I've also been lucky enough to practice in a lot of different settings because of all the moves, so primary care and specialty. So that's a little bit about me. I see that Jacqueline started us off. Thank you, Jacqueline. She says, good morning, joining from New Mexico in her clinical rotations. Okay, welcome, Jacqueline. What about you, Anna? I see Anna is on today. I see Jakaria, Pooja, Rosalind. Go ahead and introduce yourselves and just tell me where you're joining from. For the sake of timing, I'm going to jump into the content in our game today. Hi, Anna. Good morning. Um, and I still want you guys to make sure you're warming up that chat box because we're trying something fun and new, and I really want you guys to engage with me today. So, good morning, Punja, joining from the hospital setting, or you are in the hospital. Maybe you're in the middle of your shift. Clarify that for me. I hope everything's okay. Learning objectives. This is not a webinar for CEs, but I like to put those learning objectives out there just for good practice so you guys know what you're going to get out of today's webinar. We're going to make sure that we are able to identify those commonly seen eye conditions in that outpatient primary care setting, right? So most of us, you have not quite told me yet, but most of us are in that FNP track or adult gerio primary care track. So it's really important, especially for those of us who have had experience as RNs on the inpatient side, to remember the setting that you're in and really answer questions and be thinking like a primary care clinician in that outpatient setting. So we're going to talk about some of those commonly seen eye conditions, and I'm going to test your knowledge with a little game. I also want you to be able to demonstrate, is this normal or abnormal? That's really important. So we're going to talk about some of those signs and symptoms that we see in our normal day to day when patients come in. And then, most importantly, really be able to explain and understand when something is urgent and what we need to do about that so that we are preserving our patient's vision, right? That's really, really important. Hello, I see some students also participating internationally, which I really love. This is why I love asking you guys where you're joining from. I see Nick is joining from the Philippines. I see another student joining from West Palm Beach, Florida. So both domestic, international. I love that. Poonja, I'll be thinking about your mom. I hope she is doing well today. Thank you for joining us. And maybe your mom can watch too. Give her a little something to do while she's getting her chemo. Kaylee's joining from Idaho. Very nice. Welcome, Kaylee. Great to see you. All right. I'm trying something new, so I want some feedback at the end, okay? You can give me direct feedback. You can email me, whatever you like, but I want the feedback. We're going to play a little game. Is it acute or chronic, right? So let's jump into it. I'm going to describe the condition. First, I want you guys to tell me, what do you think it is? And then I want you to tell me, is this acute or chronic? So we've got a nice little picture of this one. Patient might come in describing it as their eye redness, swelling in that white part of their eye. So what's that called? Throw it in that chat for me. They might also have some irritation and redness and swelling on that inner eyelid. They might describe that discharge as thick, crusty. They woke up in the morning with that crusty discharge on their eyelid, right? It's sticky. Maybe it's yellow. Maybe it's green. They may describe it as purulent, though that's more of a medical term. So we may describe it as purulent in the chart or maybe on the exam question that pops up. So purulent, what does purulent drainage mean, right? Highly contagious, we know that. And oftentimes it starts in one eye, but because it's highly contagious, it can spread. So what do we think this is? Kaylee's saying it's bacterial conjunctivitis. Anna's saying this is acute. Do you guys agree? Okay. GW, sorry, I don't know your name. Tell me your name. Your handles are hard to figure out who's who, but Aman, Joshua, also from the Philippines, very nice. I'm going to call you G, and you said conjunctivitis as well. So, what is this? We think Kaylee's saying yes, it's bacterial conjunctivitis. Jacqueline's giving me a thumbs up, and we think it is acute. Very good, you guys. So, what were some things that popped out with this, right? The discharge is really important. What does purulent discharge mean? Some of you said that. So, Anna's saying it's pus. It's continuous pussy discharge, right? So when you wipe it, you're going to use a little cotton ball in your exam room. You're going to wipe that from the inner portion of the eye, from the eye all the way across. And as you're seeing that patient in that room, you're going to see that pus is starting to build up again. And that's what that patient is describing, right? It's pus. And why? So always ask yourself the why, right? Why are we seeing pus with bacterial conjunctivitis? Who can tell me why? What's happening? What's the pathophysiology there, you guys? Very good, Manali. Excellent. Yes, this is acute bacterial conjunctivitis. This is an acute condition. Excellent job. So remember, your body's defense system is actually fighting that bacterial infection. So that's your white blood cells really trying to attack that bacteria, and we're getting debris. So pus is that debris, right? Highly contagious, does spread from one eye to the other. What do we need to do for this patient? Let's take it one step further. So we know this is an acute condition. What are we going to do for this patient? What is the most important thing to do for this patient? What's that treatment going to look like? Antibiotics. Kaylee says antibiotics. Do you guys agree? Yes. What if it's absolutely, we're going to treat this with antibiotics. Bonus question, what kind of antibiotics? If we have a kid, are we going to do eye drops? Are we going to do ointment? What does that formulation look like? Jacqueline says ointment. Very good. Why, Jacqueline? Anna says ointment. Love it. Why, you guys? Why are we going to use that ointment? With our kiddos, I don't know if you as an adult, I have two small kids of my own, so I have had conjunctivitis, unfortunately. And even as an adult, it's really hard putting in eye drops. For those of you who have dry eye and you're putting in eye drops, it's really hard to keep that eye open. There's no way the kiddos are keeping their eyes open. So that ointment actually does a better job of staying on that eyelid and getting into the eyelid so it can fight that bacterial infection. Yeah, easier, hangs around. Very good, Anna. Awesome, awesome job. What else? What else do we need to educate this patient on? What are some other treatments that they should be doing at home? What if they wore contact lenses? What do we do about that? Eye hygiene. Very good, Poonja. Eye hygiene. What do we do with our contact lenses? Do we just clean them and pop them right back in? What do you guys think? Toss them. Yes. Unfortunately, we're going to have to toss them, right? We really want to make sure we're not making it worse. So we're going to remove those contact lenses, not wear our contact lenses during the duration of treatment, and really get a new set of contact lenses. Very good, Anna. Yeah, we do not want a pseudomonas, right? A pseudomonas infection. Kaylee says, we also want to make sure hand hygiene. Absolutely. We're avoiding contact so it resolves. No contacts. Jacqueline's also saying no makeup. Very good. Get rid of the makeup. Sunglasses, good. You can protect those eyes. And then also, what else do we want to make sure we're doing? We're preventing that spread. So we're not sharing what? We're not sharing towels or anything like that. And then you can use those cool washcloths to reduce the inflammation, some warm compresses. Awesome, awesome job, you guys. All right, next condition. Our friend here is coming in and she's describing sudden changes in her vision. She might also describe it as she has some tiny specks, squiggly lines that seem to drift through her visual field. She's getting flashes of light, maybe in one eye or both eyes. Maybe she describes it as a curtain-like shadow over that visual field. It's painless. What do we think is happening in this patient? This one's a little bit more tricky. But what is the most likely diagnosis for our friend? Remember, sudden vision loss, seeing those tiny specks, squiggly lines, maybe some flashes of light, partial vision loss. Okay, Kaylee says retinal detachment. What do you guys think? Absolutely. Retinal detachment, we're really going to be looking for those flashes of light, right? Changes in the vision, acute changes. That curtain, it's painless, right? So retinal attachment, and it is acute. Awesome job, you guys. What are we going to do? So what is a retinal detachment? Put it in the chat for me. What is a retinal detachment, you guys? Awesome job, Nikki, Monali. That's right. Retinal detachment, acute. What is a retinal detachment? So always ask yourself when you're looking at these conditions so that it's not memorizing, make sure you're asking the why. Do I know what this condition what this condition is, and why am I seeing these assessment findings, right? What are these signs and symptoms? Why am I seeing them? So what is retinal detachment? Bonus points. Who can tell me? Come on, you guys, think about it. Retinal detachment. What do we think? What do we think? Oh, this one's a tricky one. What do you guys think? Okay, Anna's guessing it's that optic nerve separation. What do you guys think? Is it the optic nerve from the retina? Okay, close. It's not that optic nerve, so it does have to do with the retina. Anybody else want to take a guess? And I'm looking at all my channels. Very good, Monali. Yes. Yes, the retina is actually pulling away, right? So it's a hole or a tear in that retina. And what ends up happening is fluid ends up passing through and building up underneath the retina. So for a long time, those patients may not have symptoms or they might have some vision changes, see some of those tiny specks before they see those flashes of light with that full detachment, right? And we can see that full flat when we dilate the eyes and look back there. So it's more about that fluid gradually pulling that retina away from its underlying tissue and causing that detachment, right? So it doesn't have to do with the optic disc, very close. I'm sorry, the optic nerve, but it's more about the retina separating from the tissue specifically. Very good. So, what are some risk factors? So, what happens with these patients? Why is this an acute condition? What do we need to do for this patient? What are we worried about? What are we worried about? So, we're having some sudden vision changes. Yes, definitely. If the why, if the pathophysiology is not making sense, this is a good opportunity to mark it down after the webinar, go read more about it. But the retina is attaching from that underlying tissue, from the actual tissue wall itself. Very good. It can lead to permanent vision loss, says Jacqueline. Absolutely. So if we don't do anything about it, this is painless, sudden vision loss or loss of visual field, but it can lead to permanent vision loss, blindness. Very good, Milani. Absolutely. So this is an acute condition. We need to get this patient over to ophthalmology or the ER if you don't have an ophthalmologist. So what are some risk factors? What do we see as increasing our patient's risk for retinal detachment? Yeah, Kaylee, Kaylee asked a really good question. Is diabetes a risk factor for retinal detachment? What do you guys think? What do you guys think? Pooja says yes. What do you guys think? Anybody else? So this is a tricky one. Kaylee, I would say diabetes definitely affects the vasculature in the eyes, right? Listen to my lecture. I can talk about it all day, but the vasculature itself, when you have high levels of blood sugar in your blood vessels, it's going to affect both the microvasculature as well as the macrovasculature. But it doesn't directly relate to retinal detachment, right? Because retinal detachment is actually more about the retina itself detaching from that tissue. So it's not directly correlated. But that's a really good question. So with the eyes, what are those risk factors for retinal detachment? Well, we see age. So if we have a diabetic patient who is older, it could be part of the picture, right? So age certainly can contribute to retinal detachment. We also see if they had any kind of, absolutely, Jacqueline, that's right, previous eye surgeries or trauma in the eye. So anything that maybe they had cataract surgery, anything that manipulated that tissue in the eye, that's going to put them at an increased risk for possible tears or holes in that retina, right? Family history also, right? So we want to really be thinking about what does it mean? What is retinal detachment and what are those risk factors? So it makes a little bit more sense of the why, right? So diabetes is not a direct risk factor, but it can all be comorbidly related, right, with their underlying eye conditions, but not directly related or correlated. Very good, you guys. Awesome. Okay, ready to go to the next one? So this patient comes in. They actually are describing this as painful. They have a pus-filled red bump on that eyelid, and they said to you, this popped up overnight. What do we think this is? What is the most likely diagnosis? And it's on that eyelid, it's a bump, it's filled with pus, it's really big, red, swelling, pain. What do we think this could be? What's the most likely diagnosis? And then is this acute or chronic? Yes, Anna, Kaylee, locking in their answers. Anybody else want to weigh in? This is a hordulum, a sty. Very good, Jacqueline. Absolutely. Yeah. So is this acute or chronic? What do we see with our styes? Is this acute or chronic? What do you think, Rosalind? What do you think, Jakaria? What do you think, Manali? Acute or chronic? Acute. Very good, Jakaria. Awesome job. Absolutely. So this is an acute condition. So what is a hordulum? Bonus points. What's a hordulum? Bonus points. What's a hordulum, you guys? Describe in your own words. Type it out. Very good, Manali. It's also known as a sty. Very good. What is it? Very good. Absolutely. Anna says it's a blocked follicle. Do we agree? Yes, this is a bacterial infection of that eyelash follicle. So sometimes it could be the oil gland or the eyelash follicle. Absolutely, it's bacterial. So what's the treatment? Are we giving antibiotics for this? What do you guys think? I see it in clinic all the time. Are we giving antibiotics? Anna says no. Do you guys agree? Are we giving antibiotics? Yes or no? What do you guys think? Absolutely not. That's right. So do not be the provider who gives antibiotics for the sty or the hordulum, right? This is something that usually resolves in 1 to 2 weeks with using warm compress. So this is going to be an opportunity to educate our patients. What happens if we're just prescribing the antibiotic ointment? Could we build some resistance to the antibiotics? Absolutely. So when we actually need it, it's not going to work. We have to step up the antibiotics, right, to a broader spectrum. So we really don't want to do that. So we want to be mindful of when we're treating with antibiotics and when we're not. This is a bacterial infection. However, warm compresses usually resolve. If the patient's not seeing any resolution 48 hours, they need to come back in, right? But really educate this patient. Make sure they're not picking at it, right? That can worsen that bacterial infection. Just warm compresses 4 or 5 times a day. It's kind of a pain in the butt, but making sure good hand hygiene, good eye hygiene, it should resolve. Awesome, awesome job, you guys. All right, let's go to our next one. This patient comes in, he looks comfortable, cool, just sitting in your room. You're asking him some history questions, you're doing a thorough HPI, and you notice that he's describing, you know what, I have lost some of my peripheral vision, or maybe you're picking up on it on your physical exam and you're asking him a little bit more detail about it. He's saying, yeah, I see a couple of blind spots in that peripheral vision. Maybe he even describes it as tunnel vision, right? His central vision loss. Sorry, his central vision is preserved, but his peripheral vision loss has gradually been going away. He is over 60 and it's painless. It doesn't really bother him. He's just noticed it and you're noticing it on exam. What do we think this could potentially be? What is this condition? What do we think, you guys? All right, Anna says macular degeneration. Pooja says macular degeneration. What do you guys think? This one's a little tricky. I was trying to go for open angle glaucoma. And the reason for that is because typically with open angle glaucoma, we don't see signs and symptoms, right? Some really early signs, we may see some peripheral vision loss in our patients, right? But the fact that the age is over 60, we want to make sure that they're getting their routine eye exams because they're not going to have symptoms until it becomes acute, right? Until that pressure has built in the eye. So that's why they call it the silent thief of sight. So I was trying to really hone in on we need to be making sure our patients are getting their routine eye exams. That's right, Kaylee. Absolutely. So with macular degeneration, it's a little different, right? And this is a chronic, so going back to glaucoma, this is a chronic condition, right? So we need to make sure our patients are going in for their routine eye exams. So going over to, let's go over to this slide and we'll go over what we talked about. So with that macular degeneration, it is age related. So that may have thrown some of you off, right? But the vision loss is more of that central vision loss, right? The peripheral is actually preserved. So that's the difference between that what that glaucoma and the age-related macular degeneration that I was trying to get at. But what we reviewed today, so let's review those conditions. So we reviewed bacterial conjunctivitis. Absolutely, one of the most common conditions that you're going to see in that primary care outpatient world is conjunctivitis. You have to really be able to figure out, is this bacterial? Is it viral? Is it allergic? And then you have to really be able to determine, okay, how am I going to treat this and what's that education behind it? So when you're studying, know the why, know the pathophysiology so you can understand those signs and symptoms, know how you're going to diagnose it, how are you going to treat it, and then how are you going to evaluate that it's working, right? That's really important. So oftentimes, what I tell students is things that get confusing, look at them in comparison to one another. So can you tell the difference between bacterial and viral? Can you tell the difference between allergic, bacterial, and viral? So what are the big differences here? So tell me what's the difference between viral and bacterial? What do you guys think? So it's more about the discharge, right? So with that bacterial, we described it as thick, purulent, that pus, right? And they're waking up with a crusting. Sometimes with viral, we might also get some crusting, but really it shouldn't be pus. It's more of that watery discharge. And we're seeing some other viral signs and symptoms, right? Patient has an upper respiratory infection, most likely viral. They're getting it. Sometimes it starts in that one eye, but both eyes pretty quickly. It's pretty hard to tell between bacterial and viral. I've gotten tricked by it myself in clinic, right? Started a patient thinking it's bacterial conjunctivitis, no other symptoms, and then their viral prodromes start, right? So you really have to be able to decipher between the different types and also educate your patient so you can say, hey, if you start to have X, Y, and Z symptoms, then it's likely viral and we don't need the antibiotic, but we're going to start treating with the antibiotic since we're not seeing any other signs and symptoms and we're seeing some pus, right? And it could be both, right? They could have a bacterial conjunctivitis along with an upper respiratory infection that's viral. So both can happen. With allergic, we're seeing bilateral because with all other allergies, right, signs and symptoms are going to be more systemic. So we might see some sneezing, runny nose, might have patients coming in describing their eyes as grainy, right, like sandpaper. It's really uncomfortable for them. It's itchy. So it's more of that allergic picture for them. So overall, step back and look at the picture. What's going on with our whole patient, right? We also talked about retinal detachment. This is absolutely a medical emergency. You guys pointed out you want to make sure that we are not going down the path of permanent vision loss. So we want to make sure we intervene quickly with these patients. But there are a lot of other retinal disorders that we do commonly see in primary care. A lot of you were talking about this in the chat. So diabetic retinopathy, we really want to be looking at that microvasculature, right, of the eyes. That's important. Also, age-related macular degeneration, we talked about that, two different types. These are things that are going to be diagnosed by ophthalmology, but we do need to work with our patients and work with the ophthalmologist to partner and make sure that we are educating our patients, signs and symptoms, treatment plans, evaluating that that treatment plan is working. So we talked about those common retinal disorders as well. We also talked about those common outer eye eyelid conditions, right? Horgillum styes, very common condition that comes in. How are we going to identify that? How are we going to identify it and determine the difference between that horgillum and the chalazion? Who knows? Who can put that in the chat for me? What's the biggest difference between that horgillum and the chalazion? What do you guys think? So remember that horgillum, we described it as it's really painful, pops up overnight. That patient is very aware of it, right? And Pooja says location, absolutely. Horgillums typically happen in that lower eyelid, whereas chalazions happen in the upper eyelid, but it can happen on the upper eyelid for the horgillum as well, but it's more common in that lower eyelid. What else? What about how it comes on? Kaylee says horgillums are painful. Chalazions are typically not. Very, very good. So chalazions typically take a while to come on. They're not going to pop up overnight. It's more gradual and they're painless. Whereas the horgillum is painful and it really pops up overnight. Awesome, awesome job, you guys. So really, when you're looking at these conditions, and it's okay if you don't know everything, you want to make sure you're marking down what you don't understand and go back and read. That's the whole point of practicing with these different types of games and our question bank and all that fun stuff. So with glaucoma, also different types of glaucoma, we were talking about that open angle, which is more chronic, it's progressive. So we really want to make sure, oftentimes, again, asymptomatic, even in angle closure, it's asymptomatic until we have an acute emergency, that acute blockage. So we really want to make sure these are chronic conditions. We are getting our patients over to ophthalmology and they are seeing them routinely for their eye exams, especially as our patients age, where this is going to become more of a risk factor for them. So big red flags to take away from today's webinar. Anything that's sudden, sudden vision loss, sudden changes in vision, that should be a red flag. You need to investigate what that is. Eye pain, we're talking about pain where they really can't open their eyes. Sometimes with allergic conjunctivitis or more benign conditions, patients might describe their eyes as painful, but they can sit there comfortably. They're opening their eyes, they're talking to you. It's that gritty feeling. So you have to ask a few more history questions just to decipher what type of symptom they're having. But we're talking about eye pain where they can't open their eye, that photophobia, same thing. They really can't open their eye in that exam room because of the light. That should be a red flag we need to investigate. Those headaches with our vision loss, again, red flag. What are we worried about with that? What are some potential differential diagnoses with that headache accompanying that vision loss? What do you guys think? What do you guys think? Absolutely, Manali. That's right. Absolutely. Yeah, could be a tumor. I'm thinking something more acute. So tumors take a long time, right? I'm thinking more about like hemorrhage or blockage, right? In that vasculature, we're seeing some headache. So headache is no longer our primary symptom, right? It's a secondary headache. Something else is going on with that vision loss. Absolutely. Stroke. Very good. So any recent trauma to the eye, decreased visual acuity. Whenever my patients come in with eye complaints, my medical assistants know to do a visual acuity for me. So I want to make sure that their visual acuity has not changed, has not gotten worse. I'm going to be looking at their pupillary reaction in the office on my exam, but we really want to make sure any of these red flags we are investigating and we're referring out urgently. Okay, so we're at time. Okay. We have a couple of Q bank questions. So for those who need to hop off, you can hop off. I will not take it personally. I know you planned for 30 minutes. What I wanted to do, if this will let me, was go over a couple of QBank questions with you guys. We're going to go right to that Archer Review website. You're going to go into my student dashboard so we can play around with it. But we have a lot of great things. So let's hop into that. And we're going to do a couple of review questions. Here's my dashboard. So when you're in your dashboard, what I always tell students is if you're new to our dashboard, you're new to the SurePass and you're just starting, so you have your QBank, you've got your video library, you have your mentoring session, your study calendar. It can be a lot. It can feel overwhelming and students are like, where do I start? I always say go to this create test. And the best place to start is really with this readiness assessment. You can choose if you've decided which boards you're taking, you can choose. If you haven't, then it's okay. Just pick one of them. It's not a big deal. And then what it'll do is it'll create a 75 question readiness assessment for you. And when you take that readiness assessment, it's nice because then you can go back and look at what you got right, what you got wrong, and read the rationale. So as you're doing it, let's do it quickly. It'll just go through as if you're taking an exam. Once you're done, you end the test. We're going to go ahead. We're going to end this test. It's like you only answered 3 questions. Are you sure? My dashboard looks awful because I do this all the time. You can view your results, and this is what I want to show you guys. So the chances of passing, we put you on this spectrum. If you're in this high or very high consistently for 3 to 4 readiness assessments, then we feel pretty confident that you know about 80 to 85% of the content. You're ready for your boards. If we're not, we have areas where we can work on, and this will help you figure that out, right? This readiness assessment. So what I really like is you can go right back into those questions. So this question ID, you can go right back in and it'll show you some statistics. What was the difficulty? How many percent of your peers got it right or wrong? What was the subject, the lesson? So you can really go back and be like, okay, I need to be reading a little bit more about pediatric, reproductive pediatric in that assessment domain. Remember, nurse practitioners, we need to be able to assess, diagnose, plan, and evaluate. So here it tells you the rationale. You're going to read through the rationale. You can watch the video that relates to that. But most importantly, I want you to be pulling those key things that you do not understand from these practice questions and going back and reviewing those. That is the most important thing. So you can do that once you've done your readiness assessment. You can pull these questions. You can go back into them. You also can look at it more of a high level in your statistics and be like, okay, well, it looks like I'm doing well in pharm, but I need a little bit more help in pediatric. It can really help you kind of focus that study plan. Then once you have your top 3 areas that you need to go back and study, here's some study calendars in here, depending on your needs, where it can really show you how to focus that study plan. So say you identified cardiac, you can tailor these study plans, but say you identified cardiac, whatever area you identified you need to go through, we're going to focus on that area one day at a time and focus our practice questions on that area. Because the idea is we're not just blowing through practice questions, we're really taking them to identify knowledge gaps and fill those knowledge gaps. So we need to know the why, and we need to know how to assess, diagnose, treat, and also evaluate that condition to make sure our treatment plan is working. So how do you get those practice questions? So say it's your cardiac day and you've done your reading about cardiac. You now want to go through and do your practice questions. You're going to go back into your QBank. You're going to create a test. So we're going to do it in time mode so we can see how long it takes us. And then we're going to do our unused, and we're going to alter this to 25 questions, go next. And we're going to do, you know what? We're going to do pharmacology, adult, geriatric, and it's my cardiac day. So I'm going to select cardiac. And it's going to give you 25 questions in cardiac. So that's how we're going to focus our study, right? That's really important. And then you can see in our study plans, we have some readiness assessments built in there so that you can really see, am I making some progress, right? And you should be seeing some progress. If not, definitely shoot me an email. What else can I show you guys? Let's see. The other thing I wanted to show you when you're in your SurePass, so this library, Your video library, you should have all those videos for you to go ahead and review. You also have a recording of our 1 day live review, but with the SurePass, you get to attend our 1 day live review. So make sure you sign up. We have 1 day live review scheduled from now through October for peak season. So you can sign up for any of them with our SurePass, whichever one works for your calendar and your test date. How many of you know when you're testing? How many of you have your test date already? Maybe yes, no. I know some of you starting clinicals, maybe not ready for that yet. It's also a really great way to really review, do I know common conditions before, or common versus uncommon before I go into my clinical rotation, right? So that's really helpful too. Then we're going to look at under live webinars, we have not only our power prep, but also our other webinars. So whether it's free or paid, it'll tell you here, and you can go ahead and register right in your student dashboard. We also have those sessions, those mentoring sessions. So tomorrow we're doing part 2 of HENT is small group tutoring. So you can sign up for our small groups, you can sign up for one-to-ones, whatever you need and whatever works with your schedule. So I wanted to walk through the different packages with you guys just so you can see how to navigate this student dashboard. I think most students don't realize all the great things that they have in there with that SurePass. Going back to our webinar, so our SurePass, if you scan this, it's probably the best deal. But you can also do it individually and just attend a live review or just get our question bank or just get our on-demand videos, whatever works for you. But I highly encourage you, if you're feeling stuck, if you're feeling like I'm not making any progress on these readiness assessments, I'm not understanding, or I don't even know where to begin or where to go from here, reach out to me. So this goes directly to my email. You can always schedule a one-to-one tutoring session with me, but reach out and I can help guide you, right? As Anna knows, I love to hear from my students. Anna shares a lot of great things with me about what they're doing in their current coursework and whether things are helpful that we present here at Archer. So I want to hear from you guys. Please don't be shy about that. And with that said, we're going to do 3 practice questions related to HENT that I pulled from our question bank. Okay, so ignore the picture. It has nothing to do with the game that we played before. I just had limited stock options. So, or photo stock options. So this is not related, even though it's the same picture, to the game we played earlier. Let's read through this question and answer in our own words and practice how this might appear in a test style, board style question. So 60-year-old Asian female presents to the office with complaints of left eye pain and redness, states that pain started suddenly yesterday. It's getting worse. She also has a headache on that side, as well as nausea and vomiting. She thinks her vision is different, but she admits to keeping her eyes closed due to the pain, so she can't really tell, right? She's not able to open her eyes. It's just really painful, so she's been keeping her eye closed. She wants something because she has been taking Tylenol and that hasn't worked, right? And now she's experiencing some vomiting. So on exam, your eye exam reveals hazy cornea with a dilated fixed pupil, conjunctival hyperemia, and inflammation of that anterior chamber. So it's giving you a lot of juicy information. What is the most likely diagnosis? What do you guys think? A, B, C, or D? And with this, if you guys have listened to my test taking strategy lecture, if not, you can find it on our YouTube channel. You can find all these webinars on our YouTube channel. Go back and look at the method that we talk about here at Archer. How do you break down these, what we call clinical vignettes, these case scenarios that can be really meaty sometimes, right? First, you're going to ask yourself, what is the question asking? Then you're going to read line by line and pull out those keywords like her age, the patient's demographic, right? She's talking about left eye pain, redness, sudden changes, right? Sudden pain, it's getting worse. So those are all keywords to pull out. Nausea, vomiting with the headache, never like to see it, right? Unilateral headache, vision change, pain, photophobia, she can't keep that eye open. Tylenol's not working, she's vomiting. And then the way they're describing what you're seeing on exam, that dilated, fixed pupil, hazy cornea, they're giving you a lot of information here. So Anna and Pooja say B. What do you guys think? What do you think, Manali? What do you think, Jacqueline, Rosalind? Jakaria. What do you guys think? And B is correct. Absolutely. This is describing acute angle closure glaucoma. So this is a medical emergency. Yes, absolutely. Good job, you guys. Let's go to the next one. Patient comes in for evaluation of bilateral eye irritation with redness, tearing, and itching. Patient has no other symptoms, no recent illnesses. On exam, there's bilateral conjunctival injections, no crusting, clear, watery drainage bilaterally. Which of the following diagnosis is most likely, A, B, C, or D? So again, what is this question asking? They want you to be able to diagnose what's at the top of your list of differentials. And what are those key words? Let's go through and pull it out. So bilateral, eye irritation, redness, tearing, itching, right? Patient has no other signs or symptoms. On exam, you're seeing bilateral conjunctival injections, no crusting, it's watery. What do we think? A, B, C, or D? And ooh, look at that participation. I love it. Absolutely. So this is D. This is allergic conjunctivitis. And it says no other signs and symptoms. Maybe next time I'll throw in something like, oh, they have seasonal allergies. They also have maybe some eczema, some skin conditions, maybe some asthma, right? The three triads. So that'll skew you a little bit more towards the allergic conjunctivitis, or it's seasonal, it happens this time of year, all that good stuff, right? All right, last board style question before I let you guys go. Nurse practitioner is evaluating a patient with a lump on the eyelid that has persisted for 1 month. On that right upper eyelid, above the eyelashes, there's a 0.5 centimeter firm, non-tender nodule. So, which of the following is the most likely diagnosis? Remember keywords. What is this question asking? It wants you to diagnose it. Nurse practitioner, you're looking at a lump. It's on that eyelid. It's persisted for 1 month. So is this something that popped up overnight, or is this something that's more gradual? It's on that upper eyelid above the eyelashes. It's firm. It's non-tender. What do we think this is? A, B, C, or D? What do you guys think? And the answer is B. Absolutely. This is a chalazion, right? So awesome, awesome job, you guys. I really appreciate your taking a risk with me and playing this little game with me today. I want your feedback. Did we like the game? Did we not like the game? Should we do more of these? Should we not? I really want to hear from you guys. If you scan this, you'll go into that student dashboard, but on our website, you should see our small group under tutoring as well. And we have a small group part 2 or part B for HENT tomorrow. So if HENT is something that you've identified, I need to work more on this, join us for the tomorrow small group. I'd love to see you. It's a lot of fun. But either way, reach out to me and make sure that you're getting the support that you need. So Pooja says, can you go back to the second question, please? Absolutely. What is your question for the second question, Pooja? So the allergic conjunctivitis. What was your question there? Anna says fun. Thank you, Anna. You're always my cheerleader. You're so sweet. But I want some, I do want what worked for you, what didn't work for you, what would you like to keep, and what would you like to do differently next time? Think about it in that way. I did just complete a leadership course and I'm trying to think about how I'm supposed to receive feedback. And I remember the acronym, but I don't remember what it's for or what it stands for. See, this is why memorization does not work. You have to understand and not just memorize, you guys. The human brain works better that way. I see. So Poonja, you're asking which is the correct answer. The correct answer is D. This is allergic conjunctivitis. Yeah, D is the correct answer. Does that help you? All right, you guys, I'm going to stay on for a few minutes just to collect some of your feedback, but please don't hesitate to reach out to me. You also can send me an email with your feedback if you're more comfortable that way. Um, but I really want to make sure that these webinars are engaging and fun for you guys and meaningful for you when we're spending the time together. So enjoy the rest of your day. Thank you so much for all your participation, and I'll see you at the next webinar, hopefully tomorrow's small group or in a couple weeks with a live review. Good luck studying, you guys. You're going to do great. You're so welcome, Takaria. You're welcome, Poonja. Oh, good, Jacqueline. I'm glad you guys like the game. Yeah. I was trying to make it fun. Like, how would I enjoy testing my knowledge? So it was a little bit of an experiment today. So Jacqueline's asking, how do we join the small group? Really great question. If you scan this, it'll take you to our Sure Pass. But that's not the most direct way. So if you go into nurse practitioner, so this is our website, just Archer Review. We're going to go into nurse practitioner. You'll see this private tutoring. So even though it's not one-to-one, you could book one-to-one. If you scroll down, you'll see that that group session is available for tomorrow at 11. So you can sign up for that group session. It's kind of hidden right now. We're doing some good updates, needed updates on our website so that it's not as many clicks to find us. But again, when you're on the main website, you want to go into nursing, nurse practitioner, then private tutoring, then FNP, and then you'll see it there, the group tutoring right there. Hmm. Wonder why my other ones are not popping up. Oh, right, because I'm on vacation the next 2 weeks. Oh, Hiva. Too many things. Yeah. Hope to see you tomorrow, Jacqueline. That'll be fun. You're so welcome. All right, you guys. Enjoy the rest of your